Is Dr. Asad joined us? The moderator.
For him, I didn't see. Dr. Asad Shah, I think, yes. Dr. Asad, can you hear me? I think it's already joined. Dr. Asad Shah?
Welcome, Dr. Asad.
Hi everyone, Assalamu alaikum warahmatullahi wabarakatuh. I am Dr. Asad Shah and I'm working as a consultant neurosurgeon in Punjab Institute of Neurosciences. And today we have a session with the chairman, Professor Hamid Akbar Sheikh, who's a professor of neurosurgery in Department of Neurosurgery, People's University, Nawabshah. And he has a significant role in Pakistan Society of Neurosurgery. And he is a very famous, well-known neurosurgeon of Pakistan. And we have our guest speaker today, Professor Hussein Bisirgulo, who is associate professor at each university of Turkey and former Roton Fellow and specialist of endomicroskull-based surgery. And before we start our session, I would like Professor Hamid Akbar Sheikh to have a few words for this session.
Assalamu alaikum everyone and welcome all of you in this meeting. So I think the anti-skull base, the very complex surgery field in the neurosurgery. So some people are doing at the institutes in Pakistan like PIMS and JPMC and several hospitals. We are also doing, but not complex cases, but only the endoscopic transspinal and the bifrontal phalangotomy we are doing at our institute. So I welcome all of you and I am pleased to join all of you. And we should start, I think we should start the meeting. And I especially welcome Dr. Hussein with the Bisirgulo. Sorry if I am not pronounced the correctly.
It's okay. Bicheroğlu. It means cutter.
Means cutter.
Yeah.
So you are a surgeon.
I am the son of the cutter. Oglu means the son. Bicher means the cutter. So I'm the son of the cutter.
So you are also a cutter surgeon means a cutter.
Yes, I'm a surgeon, son of the surgeon.
So I am pleased all of to meet with all of you. So we should start the meeting.
Okay, I can start now. I will start my chronometer. Thank you for your nice invitation. Today, I will try to explain my experience about the anterior olfactory nerve. Sorry, the olfactory nerve. I will share my screen. Do you see it now? Do you see it?
Yes, we can see.
Okay, very nice. Do you see the cursor, the mouse?
Yes,
we can see.
Let's start. The anatomy of the olfactory nerve and approach to the anterior skull base. So today, I will try to explain the anatomy of this area. So this area, sorry.
Please make it in full screen mode.
It's full screen now.
Presentation. Yeah, presentation mode.
Really?
Can you?
Is it now full screen?
Not yet. It's down.
Okay.
You can press on the presentation mode in the lower right. Yes. Yes, that's great.
Is it now okay?
No, it's still
Just
on.
press it. Mhm.
Sorry, I will do it like this. Let me share again.
Mhm.
So I will do it like this. Is it okay now?
It's still not. I don't know why.
We see the
You are pressing, but it
not
is
on
not.
presentation mode.
Mm.
If you know, doctor, as you do previously, do sharing to the screen of the computer. So anything in the screen, we can see it. Not don't choose the PowerPoint file. Choose the screen, computer screen. I think it will be better.
Okay, I will try to do it now. I will. So do you see now? Sorry.
Yes. Okay. Now open the presentation mode.
Is it
Now
now?
we see your screen.
Yes, now we can see your screen.
Is it full screen now? Is it full screen now?
Yes, perfect.
Okay. I guess it's okay now. You see, okay? Okay. So I will explain this nerve, the anatomy of this olfactory nerve, but it is not just a nerve. It's not just a simple anatomy, because there are two main approaches to this area. The first one is the transcranial approach, which can be bichronal, subfrontal, pterional variant, frontotemporal, fronto-basal approach. It's okay, orbitofrontal approach, but there are two main approaches, which transcranial approach and transnasal approach. So I have to explain, and with the variations and the surgical implications of both this area, which I will explain the anatomy of this nose area, transnasal approach, and of course I have to explain the anterior skull base and also the orbitofrontal cortex. So also I have to explain the olfactory nerve and its joining afferents and efferents of this central core area. So this is my ambition about this area. Do you see it now? Did it switched?
Yes.
Okay. So when we look at this basal part of the brain, you see both the olfactory nerve. So this is the olfactory bulb, which is an extension of brain inside the nose. And this is the olfactory nerve. That part here is called the anterior olfactory nuclei. And that it has three or maybe two main distinctive connections. One is lateral olfactory stria, the other is medial olfactory stria. So this part here, which orbitofrontal cortex is cover the olfactory nerve, is called the gyrus rectus. This part, lateral olfactory stria, has deep connections with the Lyman insula, which is a connection between frontal lobe and temporal lobe. This, you see the fibers, mostly uncinate fascicule, but there are fibers of the olfactory nuclei, lateral olfactory stria here, goes to uncus, entorhinal cortex, amygdala, and hippocampus here. The medial olfactory stria goes directly to the septal area, and deep inside the central core goes deep inside the locus cereus brainstem, cholinergic fibers of diagonal band of Broca, and has deep connections in this area underneath anterior perforating substance. I will explain these areas. So this part is very important. And then I will show some important dissection photos of that area, the surgical view of that area, which you see the anterior skull base here, crista galli is here, frontal sinus, the right frontal lobe is preserved, and then the left frontal lobe is extracted, preserving the insula, superior limiting and anterior limiting sulcus of insula is preserved. This is the anterior olfactory nuclei. I will show with deeply. This is the optic nerve, anterior cerebral artery, anterior. This is the olfactory nerve, which has connections of this lateral olfactory striae and medial olfactory striae that goes deep inside the septal region, hypothalamus, and these are two Broca's diagonal band of Broca's. So this tiny here membrane is called lamina terminalis, which when we operate, especially with the aneurysm surgery, you can have access to third ventricle here. And I will show also this. In a deeper way, when you elevate the anterior perforating substance, you see here the medial olfactory striae, lateral olfactory striae goes to the temporal lobe here, and also you see the anterior commissure. So mostly the olfactory data is ipsilateral, but there are some connections to the lateral part. So these connections are mostly goes from anterior commissure here, and inside the underneath the anterior commissure here you see the hypothalamic region, and this is the fornix area. This is the internal capsule, caudate nucleus, and putamen. So this is a very important area, which every structure is very important. For example, this is the anterior cerebral artery, and this is the Höbner's recurrent artery, goes directly to the central core area. And when I will show the deep dissections later. Sometimes, as Professor said, bicoronal orbitofrontal approach are needed, and then you have to preserve the pericranial membrane, periost, to have at the end of the surgery to prevent CSF leakage. So when you retract all the cerebrum here, the anterior skull base is here, and this is a very complex, important structures, neurovascular structures we can see. This is the ethmoidal area, the anterior ethmoidal artery and the posterior ethmoidal artery you can see. This is the olfactory bulb, and olfactory nerve can also be seen. This is the orbita, and also the orbital nerves can be seen. The important part, even when you are doing a transcranial approach or a transnasal approach, you have to preserve or cut the ethmoidal arteries medial to the orbital area, because these arteries can go directly into the orbit, and your patient can be blind immediately. I will show the anatomy of that transcribriform and transplanum sphenoidale areas. These are the frontal sinus area, and when you performing, you can see the dura here, and after retracting the dura, you can see the olfactory nerve, gyrus rectus, below transnasally. So I have to mention about the anatomy of the olfactory nerve first. Of course, this is a olfaction, the special sense of smell. The olfactory bulb I have shown, the olfactory tract I have shown. So the olfaction here, collectively called the rhinencephalon or the nose brain. This is very important because primary olfactory neurons undergo continuous replacement throughout life. So, and approximately 60 days, they are all replaced. Primary olfactory neurons snaps with secondary olfactory neurons in the olfactory bulb, which I have recently showed. Very important data. They are sent signals directly without synapsing thalamus, but this olfactory bulb is also called the thalamus of this olfaction. It's debatable. Olfactory epithelium is very important. As I said previously, pathways to the cortical areas involved in olfaction area are mostly ipsilateral. So there's a specialized nasal mucosa and kept moist by olfactory glandular secretions. So let's look at that area and the connections. So we have seen the crista galli, olfactory bulb here, is secondary olfactory axons here, anterior olfactory nucleus, and then lateral and medial olfactory strias or olfactory tracts can be seen. And anterior commissure, as I have mentioned before, has connections with the other bulb, the other part also. There are 4 different cell types of that epithelium, which is first the primary olfactory neurons. These are bipolar neurons. Some are mitral, some are tufted cells. The second one is basal cells. These are generated throughout life, about 60 days periodically. The supporting cells, they have sustaincular cells. These are like glial cells. And 4, the secretory cells, which includes all odorant binding proteins. The connections are very important. Olfactory bulb and its projections are very important. I have to mention the layers of that olfactory bulb. There are 6 layers: nerve fiber layers, glomerular layers, external plexiform layers, mitral layers. These layers have different connections. As you should see, the layers: nerve fiber layers, glomerular layers, external plexiform layers, mitral layers, internal plexiform layers, and olfactory tract layers. There are 3 types of cells. The one is mitral cells, the other is tufted cells, and then the granular interneurons and periglomerular cells. Let's review what we have talked here. Olfactory bulb, olfactory tracts connected with anterior commissure. The lateral olfactory stria has deep connections with the brainstem and also the temporal lobe. Which parts? Entorhinal cortex, amygdala, and hippocampus. The lateral olfactory stria to the primary olfactory area goes connected with uncus. Entorhinal area, which is entorhinal, is the anterior part of the parahippocampal gyrus, the lemon insula, and a part of the amygdaloid body. Anterior olfactory nucleus is debatable, but I will show, I have shown, and I will show that part is goes deep inside the tractus, and this is the piriform cortex, and this is the entorhinal cortex, and this part, the olfactory bulb, transverse the skull base. Let's go deeper. As we have shown previously, olfactory bulb is connected with the anterior olfactory nucleus, and olfactory nucleus, anterior olfactory nucleus, connected with amygdala and hippocampus. This is the limbic part of the limbic pathways, and also the piriform cortex, and also the basal forebrain, as I have shown, the diagonal band of Broca. So this is very important connections. Also from the cortex area, or olfactory tubercle, piriform cortex, amygdala, entorhinal cortex are both connected hippocampus, hypothalamus, and orbitofrontal cortex, thalamus, and there's a deep connection with these areas. As I will show now, this is the schematic view, the lateral olfactory stria and the medial olfactory stria, which is going directly from lemon insula to entorhinal cortex, amygdala, hippocampus, and uncus. So let's see the real, not the schematic views. Let's see the real anatomy. Let's start. So this is the basal view of our brain. Optic chiasms, anterior olfactory nucleus here, optic olfactory nerves, gyrus rectus is here, brainstem, pons, mammillary bodies, anterior perforating substance are all here. This is the lateral olfactory striate area, and this is the medial olfactory striate area. So, and this part is the uncus, and that part is the entorhinal cortex. Deep inside this area, we will have temporal horn, and the head of the hippocampus and amygdala is just here. We will see now. When we retract, just take out the uncus, and to show the lemon insula, this is the lemon insula. This is the insular cortex. This is the uncus here. Just decorticate that area. You see the uncinate fascicle fibers, but there are fibers of the olfactory, lateral olfactory stria going directly to the temporal lobe. Now, this is the orbitofrontal cortex area, decorticated. This part is the orbitofrontal cortex area. This is the temporobasal area. This is the temporobasal area. So when you decorticate and retract, extract the U fibers, we will see the this optic tract, Mayer loop here, and then this is a reflection of the temporal lobe. When we go further dissections, you see the digitations of the hippocampus here, but we didn't open the ventricule yet. This is the uncus area, this is the uncinate fascicle and the lemon insula area. So this part is the olfactory region and has deep insight to the connections with the hippocampus. Let's see here. This part is the olfactory nerve area, anterior perforating substance here. Now you see the digitations of the hippocampus here and the reflection of the ventricle. Now I open the ventricle here. Now this is the head of the hippocampus, uncus, and we will see somewhere here amygdala. So this is the, as I said, as you see the Mayer's loop here also. This is the temporal basal area, and this part is the occipital lobe. So this is the choroidal fissure. Hippocampus is retracted. Here you see the amygdala here. The amygdala is the hippocampus, the head of the hippocampus is retracted. So this is called uncus, I guess. This is the renal sulcus, parahippocampal sulcus here, and then occipitotemporal gyrus is here. I have to mention about the gray matter of the brain, because without having a brief understanding of this gray matter organization, it's hard to understand the functions and the connections. Very brief, limbic, paralimbic, and association cortexes are there. This is the paralimbic areas, green, and high order areas, prefrontal cortex here. So cerebral cortex is normally 6-layer. First, the limbic region. What are the limbic regions? There are corticoid and allocortical regions. In the corticoid regions, lamination is not regular and uniformal. What are the corticoid cortexes? Septal region, substantia innominata, which is the underneath of the anterior commissure, amygdaloid complex, and also, I have to mention this, anterior olfactory cortex. So this cortex is not just a regular cortex, it's a continuation of the olfactory nerve, and it's a corticoid cortex. What are allocortical, which means old cortex? These are hippocampal complexes, the indicium griseum area, subcallosal rudiment of hippocampus, and as I said, primary olfactory cortex. These are old cortexes. And also the paralimbic region, orbitofrontal, insula, temporal lobe, parahippocampal cortex, and cingulum complexes are paralimbic, and the other areas are unimodal and heteromodal association cortexes. So let's start about the anatomic important areas. So this is our nose. I have to mention some variations about this area because anatomy, we all know anatomy, but variations are very important. We have to know and understand and realize when we saw anatomy during surgery or before surgery with the MRI and CT scans. So ethmoid bone is very important. We have cribriform plate there, and cristagalli is very important. As you see, cribriform plate. Olfactory bulb is situated here with the extensions to the nasal. The lateral nasal wall has uncinate processes and basal lamella of the middle turbinate. Lateral nasal wall has sometimes variable landmarks. These are ethmoidal bulla, superior turbinate, and supreme turbinate. Turbinates are called concha, which we have inferior, middle, superior, and supreme. The medial turbinate, the uncinate process is very important. I will show the anatomic slides. So this is the bulla ethmoidalis. This is the middle turbinate and also the septum. This is the lacrimal crest here. And this is the bony structures of that area. So when we are performing transnasal, microscopic or endoscopic approach, this middle turbinates, the middle meatus, inferior turbinates, is shown like this. When we are doing a transcribiform, transplanum approach, we are going directly to this area. But is it always like this strictness? No. We have a lot of variations in the brain. I also perform microscopic transcranial and endoscopic transnasal and nasal approach. So most time we have to understand the variations here. I was now briefly mention some variations of that area, the nasal area, which is related to olfactory nerve and olfaction. The first one I have to mention is Onodi cells, the sphenoethmoidal cells. These are the posterior ethmoidal cells, and they are associated with optic nerve. As you see, these are the Onodi cells here. The other part is the Heller cells, which are infraorbital cells. These are the infraorbital ethmoidal parts. So you can confuse. Sometimes you can say that I'm in the cranial part, or it's just Heller cells or Onodi cells. You have to be very careful. The other part is the most anterior part of the ethmoidal, most anterior ethmoidal air cells, called the Eger-Nazi cells, which are like this. And nasal and paranasal anatomical variations are very important. I will mention it quickly. Deviation, Schpur, septum bullosa, paradoxal curvature, bilateral medialized middle turbinates. This is the concha bullosa of the middle turbinate here, different variations. Lamella bullosa, medialized superior turbinate, superior turbinate concha bullosa here, as you see, and large bulla ethmoidalis, bilateral hyperaerated posterior ethmoidal cells. So when we are performing transcribiform and transplanum endoscopic skull-base tumors, this is the view of the endoscopic part. There are some important, very important anatomical structures, which either we are performing transcranial or transnasal approach. The first one is olfactory groove. These are nasalized frontal sinuses. But the olfactory groove, it has variations. We have to know the cherotypes, the type 1, type 2, or type 3 olfactory groove. Why this is important? Because we are performing olfactory groove meningiomas from transcranially or endoscopically. So the variations is very important when we are opening the surgery. So this is the after the dura is extracted, the gyrus rectus and olfactory nerve, olfactory bulb can also be seen here. The other part, the main very important structure is called the sphenoidal sinus. This is the type C, type B, and type A. So let's see some important dissections. We have seen from basal to superior. Now we will see medial to lateral. Why? Because this is the olfactory nerve, olfactory bulb here. I have shown the connections with the temporal lobe area. Inside the central core, connections with the hypothalamus is very important. The brainstem, locus coeruleus, the diagonal band of Broca, cholinergic nerve, and also this paraterminal region. This is the gyrus, cingulate gyrus, and this is the paraterminal region. So this olfaction data is also connected with this area, and this is a limbic loop. It's a very important part of this. So the olfaction is very important in our limbic system. Why? I don't know why, but it's very important. And also in some diseases, the olfactory nerve is decreased in Parkinson's disease, in Alzheimer's. So it's very predictive in some cases. So this is the close-up view of that corpus callosum region, caudate nucleus, and that this is the optic chiasm. Olfactory nerve is here, anterior olfactory nucleus is here, and also the medial olfactory stria is just underneath this area. This is the close-up view. Now we are seeing the medial part of the temporal lobe. This is the cingulate gyrus. Cingulate gyrus is decorticated to the anterior basal part of the temporal lobe. You see the the uncus here. As you see the olfactory nerve, anterior olfactory nuclei, the medial and lateral olfactory stria is connected with these areas. As we have shown previously, this is the hippocampus, and the fibers of the cingulate gyrus can also be seen going deep inside the anterior temporal lobe area. So this part is also here. As a different view, this is the anterior commissure, optic chiasm, foramen Monro, internal capsular fibers. These are the olfactory bulbs and olfactory nerves. So this is a more close-up view of that area, and another view of that lateral and medial olfactory stria and anterior perforating substance. More close-up view here. As this is a better view. This is the olfactory nerve. Anterior olfactory nucleus is somewhere here. I will show the MRI scans of that dissections later. And this part is the lateral olfactory stria, as you see, and medial olfactory stria is also here. And this is the optic nerve, and this is the lateral geniculate body. So, the last 15 minutes, I will show the MRI scan of this cadaver with preserving the vessels, and also I will show the anterior part of anterior central core, anterior medial central core area. So what we are doing now is preserving right hemisphere. So frontal lobe is preserved, frontobasal area, right frontobasal area is preserved. I have preserved all the anterior circulation, the branches of the anterior cerebral artery. Now what we are seeing is this part. I have just cut part of the gyrus rectus to show the anatomy here. This is the medial frontal lobe here, corpus callosum here. I have preserved the superior limiting sulcus and anterior limiting sulcus of insula, preserved the Lyman insula, preserved the medial cerebral artery. This part is the temporal lobe area. This part is the superior temporal lobe, which is also called the Heschel gyrus, which is also a primary auditory cortex. What we have seen here is the ventricule, anterior part of that ependym of the ventricule. So let's continue dissections to see the deep anatomy of that anterior skull base and all olfaction structures. The olfactory nerve lies underneath the orbitofrontal cortex, which is also underneath the gyrus rectus here. Anterior clinoid here. This part is also the Lyman insula, and anterior limiting sulcus is also here. Now we will open this ependyma and see the inside of that part. So what we have done is just dissect get rid of this gyrus rectus to show the connection of this olfactory nerve with the central core region. Now that part is anterior olfactory nuclei. Very important area. This is the gyrus rectus, the beginning of that gyrus rectus area. So anterior cerebral artery here. Now I open the ependyma of that lateral ventricule. But it is really hard in most of the dissections to have a three-dimensional view of that ventricule, Lyman insula, and anterior part of the insula, and anterior olfactory nuclei. So this triangle is very important. These are the anterior limiters of the central core areas. So let's continue dissecting. That part, anterior olfactory nucleus and central core area, are not directly connected. There's a white matter between that area, and this is the MRI navigation of that area. So this part is limiting central core. I have to mention a very important data here. So when you are performing a hemispherectomy, so this angle here, approximately 55-60 degrees, is very important. This is not, so this central core area is not just directly 90 degrees, it's 60 degrees. So you have to be very careful in these performing surgeries not to damage these neurovascular structures. Now, what we are seeing here is anterior olfactory nuclei, lateral olfactory stria to the temporal lobe, medial olfactory stria to the septal region, and diagonal band of Broca here. Underneath the olfactory nerve, you see the optic nerve and anterior cerebral artery, and this part is the Höbner's recurrent artery. That is the exact localization of Broca's diagonal band of Broca. This is the beginning of the anterior limiting part of the third ventricle. This is corpus callosum here. And we open the corpus callosum here. You see the two caudate nuclei here. And when you retract the caudate nuclei, you will see the foramen Monro and choroid plexus here. Now let's open this area. This area is very important because all the olfaction data spreads different areas from here. Lateral, medial, and cross-sectional with the anterior commissure. Let's see that anatomy. Corpus callosum, septal region. This is the septal area, coronally, sagittally, and axially. This is the anterior, Nucleus accumbens is here. It's connected with caudate nucleus and putamen here underneath internal capsule. This part is the anterior nucleus accumbens area, optic chiasm, third ventricle, diagonal band of Broca also here. That part is the anterior olfactory nucleus. This is very important. This is the coronal view. And when you see it sagittally, you see the white matter connection, but this part is a different area with the central cord. And then internal capsule is there. Let's dissect this part to see deep connections of that area. So, olfactory nerve, lateral olfactory stria, medial olfactory stria, anterior commissure, fornix, hypothalamus, septal region, septal nucleus are all connected with this area, and this olfaction data also goes to directly to the brain stem, amygdala, hippocampus, hypothalamus, septal region, and with the anterior commissure here to the other part of the olfactory bulb. So this is a more close-up view with the Höbner artery, anterior commissure, anterior olfactory nuclei, and lateral olfactory stria, medial olfactory stria, and these parts are also the uncinate fascicule, which are connecting temporal lobe with the frontal lobe. So I'm skipping these parts. When we elevate that anterior olfactory nuclei, what we see the brainstem, pons, third nerve, internal carotid artery, anterior cerebral artery, middle cerebral artery, and all the perforating ventricular arteries, and optic chiasm can be seen here. This is the localization of hippocampus. So now this is in the inferior of the anterior commissure. As you see, the hypothalamus is situated. So when we go deeper dissections of the right part, this is the anterior temporal horn of the right ventricle. This is the amygdala and the head of the hippocampus, posterior cerebral artery. This part is the olfactory nerve. As you see, the lateral olfactory stria goes directly to the amygdala here. And this is a very deep connections with the also hippocampus. So this is the posterior cerebral artery, and these are the thalamoperforators. And this is the anterior oblique view of that anterior commissure, fornix, foramen Monro, lamina terminalis, diagonal band of Broca, and this part also as we dissect the olfactory area. So this is the oblique view again to show both anterior commissures. These are the medial olfactory stria here. This is the medial olfactory stria, anterior commissure. Diagonal band of Broca is here. Septal region is here. This is the oblique view to show the foramen Monro, basal of the third ventricle. This is subthalamic nucleus. This is red nucleus. This is substantia nigra. And this is the lateral view of that important areas. So when we open the lamina terminalis area, you see the mammillary body, fornix, foramen Monro, adhesio interthalamica, basal of the third ventricle, and this is the pituitary stalk. So this is the deep connections of that very important area. So as I mentioned, these are the structural important areas, both transcranially and transsphenoidally. Very important to repair the fluid leaks, very important. Preventing and dealing with the complications is very important. Vasospasm I have to mention, but I have no time, I guess. Vasospasm is very important. I don't want anyone face an internal carotid injury, but it is very important to have endovascular facilities with you when you are performing endoscopic and transcranial vascular and tumoral surgeries. managing arterial is very important. Nasal complications is very important, and olfactory disorders are not so rare. So preserving every tissue, functional tissue, is very important. Sometimes we are not. We have to be careful as the ENT guys. So the best treatment of surgical complication is to avoid them. I will show just 5 minutes the anatomy of that region. This is the transcranial part, but we have limited times. This is optic nerve. I will skip these videos. So the frontal lobe is here, frontabasal area, and olfactory nerve is preserved, all the surgery. This is both a meningioma of that area and a middle cerebral artery aneurysm, both dissected. This is the postoperative view of that area, preserving. Now, as I mentioned, we perform also the transnasal approach. This is the optic lateral orbital wall orbital roof meningioma. So we decided to do it with a endoscopic way. I will not do it, but this is the nasoseptal flap here. We preserve for the CSF leakage. After preserving the nasoseptal flap, we try to get rid of the ethmoidal arteries. Sorry, ethmoidal. Open the ethmoidal area. Drilling is very important. After that, we will open and go directly to the anterior skull base area. We are now just in the nasal area. This is the cribriform plate area. After drilling that part, we will directly sense the tumor tissue. As you see, this is the intracranial part. The meningioma is also retracted, dissected meticulously. After that, this is the orbitofrontal cortex, and it is like the transcranial part, the bleeding control. This is the full extension. Why I show this area? I will show now the Haddad flap, the nasoseptal flap. Here we put that nasoseptal flap. Now I will show the MRI scan of that nasoseptal flap. So this is very important to drill the sphenoid ridge. So you see the MRI scan of that Haddad flap. This is the postoperative view. Sometimes the area of that tumors are very bad. Extension of both carotid parts, cavernous sinuses. The lateral part, as you see, the olfactory here, nerve is here, and the tumor is going to the clival areas, superior, middle, and inferior clival areas. This is the postoperative view to just mention that when you are performing with that area, preserving the carotid artery and using Doppler ultrasonography is very important. So this is late postoperative view of that area. So these are some important books I have written in my career. Unfortunately, they are in Turkish, but maybe someday I will do the English versions. This is the surgical anatomy of spine, neurosurgical anatomy of head, neck, and brain. This is the 1,000-page board review book, neurosurgical book for Turkish neurosurgeons. This is the 2,300-page, 4 volumes, surgical anatomy of function. this is a textbook in Turkish, 4 volumes, and that pain, spasticity, functional organization, cranial nerves, the functional neurologic and psychiatric books, epilepsy surgery, motion surgery, cranial rhizopathies, psychosurgery, white matter and gray matters, functional anatomy. And I have to mention 1 minute, Professor Roton, Professor Mann, rest in peace, Professor Roton, rest in peace, Professor Oliveira. These are old friends. I have to mention, of course, Professor Roton, rest in peace. This is the Roton Society meeting in Turkey, and these are all the Roton fellows, very distinguished people. So Professor Roton always said, through our brain and mind, we became aware of own soul. And then he always said, keep working, but keep working hard. Thank you very much.
Thank you very much, Professor Hussein, for this fantastic presentation.
It's 47 minutes. Yes, thank you.
Okay, we still have time if you want. So no
maybe 15 minutes questions or.
Professor Hamid Akbar, please, if you have a few words.
Inshallah, it was very excellent presentation by Dr. Hussain, and I am very much thankful, Dr. Hussain, we gave such a wonderful presentation, and I am also see the books. It was publications, so it is very difficult to manage the practice and write the books and too much editions. So it is very hard working, and I am very so I congratulate Dr. Hussain on these editions, publications, and a good presentation. Also, I saw the surgical approaches. It was also very good. So I appreciate your work. So I invite all of you, if anyone have question regarding the anatomy or surgical approaches to the skull base.
I just want to say thank you very much for the great presentation, Dr. Hussain, and also maybe remind to residents and young neurosurgeons how it is important to know the anatomy of anterior skull base, because if you will not face the tumors and aneurysm clipping in the night cases, but you will definitely face with the trauma when patient will come with a frontal sinus fracture, inner or outer plate. And this is exact time when we have to know the anatomy. We have to know how to dissect the periosteum, preserve it, and know how to stitch the dura, because these are very important structures. And usually anterior skull base fractures are not isolated. They can attach the superior orbital wall, lateral orbital wall. So this is like one of the most important area in trauma, especially in countries where the helmet is not being used so frequently for different reasons. So yes, thank you very much. It's very important information for us.
Can I say something?
Yes.
Yes, please.
We have, you know, in neurosurgery, we have developed a lot. And sometimes one people say, I am a skull-based surgery, but just transcranially. I'm a skull-based surgeon, but just transnasally. Or I'm just a neurovascular surgeon, but this is okay, very nice, very important to be specialized. But neurosurgery is neurosurgery, and you have to be competent of every region at the same time. Not I'm a skull-based surgeon, I don't care brain. No, you have to know the brain, because you have to preserve the brain. The skull-based surgery is just preserving the brain and the neurovascular structure. So it is very important. Sometimes in young neurosurgeons can separate their minds, and I just focus something vascular, but you have to know that the vessel and the functions of that supply. Thank you.
Right. Thank you.
Dr. Hussein, if I may have asked you a question. In some cases, if we have a CSF urinuria or CSF leakage from the nose in spontaneous cases, and you have a large defect, about approximately 1.5 centimeter defect in the cribriform plate, what approach do you prefer for these cases, and how do you manage to preserve the function of the infection?
I'm an old school neurosurgeon. So if there is a leakage, of course, I first try to or think about the minimal invasive part. But transnasal approach is not always minimal invasive in CSF leakage. Sometimes you have to preserve the periosteum and directly go transcranially with the old school. But in each case, I guess you have to decide separately.
So in this case, as I told you, if there is a case of spontaneous CSF urinuria, and there is a 1.5 centimeter defect in the cribriform plate, what approach do you prefer?
You know, I have shown a meningioma in transcranial approach. The defect was very big, but we could close it with a transnasal flap. So the nasoseptal flap, sorry, the Haddad flap. So the mentions, the metrics of the area is not so important. I guess the related structures are very important. So we can now close the very big areas in transnasally. So it's not a very big deal like 20 years ago.
Thank you very much. If there is anyone have any more question for Dr. Hussein, please you can ask directly or drop in the chat.
Can I ask one question?
Sure.
Yeah, sir. Just I wanted to ask that in case of recurrent CSF leak, like the case you mentioned about meningioma. So in such cases, if there is a CSF leak, only the repair will be sufficient, or you supplement it with lumbar drain also?
You know, I had 5 years ago, I was doing routinely lumbar drainage. But somehow today, in very rare cases, I don't routinely use lumbar drainage, but there are some consequences in deciding that parts. If the patient has a tendency of hydrocephalus, not hydrocephalus, but tendency, you feel it. Sometimes it is, you have to change the procedure. This transcranially is better, because if you have a tendency to hydrocephalus and you operate it with the transnasal approach, even you have to do a perfect surgery with the lumbar drainage, there will be a catastrophic problems. So you have to decide previously, or if the surgery will be very bleedy, and then maybe a secondary hydrocephalus can develop, or you destruct some important venous structures. Just temporary hydrocephalus can occur. So you have to be very careful. I'm not using regularly now, but in big cases or high flow leakage areas, it is very preferable. I put it for 5 or 7 days, maybe. So it is very good. But now the case that I did transnasally, the meningioma, I didn't use it.
Thank you, sir.
Because I avoid dissecting very laterally. I try to open very narrowly, always. I don't want to destroy everything laterally. If it is big but it is narrow, it is very nicely closed. So I really I open like I'm closing. Somebody have to close, but normally you close, so you have to open as you close.
Anyone else have any questions? Please go ahead. I think there is no more questions. So thank you very much, Dr. Hussein, for this fantastic presentation and this very nice slides and very nice information you gave us. So I ask Dr. Hamid Akbar, Professor Hamid Akbar, to say any final remark before we closing the session.
I'm very thankful all of you to attend such a nice meeting. So all of the hosts and the participants who were giving your precious time to hear the present in the meeting and hear such a nice presentation by Dr. Hussein. And I'm very thankful all of you.
Thank you very much. Somebody told that this presentation will be in YouTube, I guess.
Yes, it will be.
So they can see and follow and look at that social media. Thank you very much.
It's now live streaming on YouTube. And,
okay.
Yes, and also it will be after editing. I will put it in the Yemen Neurosurgical Society YouTube page, and I will send you the link later.
Thank you very much. See you later. It's always a pleasure to be here to talk and discuss with you. Thank you very much. Goodbye.
Thank you very much, and see you all inshallah next week, inshallah.